I think we'll call upon the next presenter, Dr. Prasanna Venkatesh Ramesh.
Can I have the mirror display? AV team? Yeah. Can I have a PowerPoint laser as well? Yeah. Thank you, APAO LDP and the whole APAO team, Moin sir, Minu ma'am, Vivek sir, for this wonderful opportunity. Can I have a laser pointer, please? So my project is on incorporating a novel 4D cost-effective. It's a self-built and a portable mix simulator in a dry lab environment, which is unlocking next-level surgical precision. So I got this idea from a mixed scenario case where you can see I'm placing an implant and it just fell off. It was under implant. So I had to implant, I have to give more axial pressure and implant the second stent first. Then I had to remove the other one. And then when I was coming back also, I failed to close the trocar and I lost the stent. So these are some of the common scenarios that a mixed aspirant faces, and then you can see I'm closing the trocar, and then I was lucky in this case, it was one of my earlier cases, but all's well ends well. So mix is a very challenging scenario, so I went back to my drawing board here, and you can see this is the innovation that I have made where it's more like a metaverse, and this is what you see through your eye, and this is what actually people see you, they think you are crazy when they see you from the outside. And not once, twice, but multiple times you can go and practice this in your trabecular meshwork surgery or your angle surgery, and when you do it right, and it's just matter of time, you can go and do it. It's called the cognitive training that I have started at my center in Trichy, Tamil Nadu, and I've also filed a patent and it's pending as well. So the purpose of this is to evaluate the effectiveness of the simulator called the IMG Hollow, and also to identify the features of a good mix simulator, because there is not much of mix simulation in market as of such. And it was a prospective intervention study with 3 dry lab sessions, 1 dry lab session per month from October, November and December after our Nepal Kathmandu meet, and 30 aspirant fellows participated in this, and this was the composition of the dry lab. So the residents or fellows with no experience did the training, and then a questionnaire was undertaken, and they became group 1, which happened on day 2, and then the real time mixed surgery was performed, and then the similar questionnaire was actually undertaken. So they themselves will form the group 2 as well after the intervention arm has taken, and the similar questionnaire. The study questionnaire was actually developed after a focus group discussion with in-depth detailed interaction regarding surgical simulations, and it had 10 items pertaining to satisfaction, accuracy, efficacy, hand-eye coordination, safe environment. So these were some of the common questions like, is it adequately prepared? Was the hand-eye coordination helped you? The satisfaction levels of the simulator, the visual feedback, and there is a pseudo haptic touch which gives you a sensation of touch when you touch your phone, right? There is a click. A similar sensation gives when you touch the instrument. Confidence level, reducing the likelihood of making mistakes, and what rating would they give, and is the environment safe, and would they recommend? So these were the parameters that were chosen, and they were also divided into quantitative analytic parameters, efficacy, accuracy and user satisfaction. Qualitative based on how are the responses, the negative responses or the positive responses, and where this should actually improve, because they are also exposed to the surgical field. And the question was actually divided into 4 points, very poor to excellent, following the Likert scale, so that we used the standard scale to actually get a methodology arrived. And you can see that 4 into 30 could be the maximum point that one can actually score. If 30 people are all giving 4, it comes down to 120. And then the marks were added and divided by 10, and standard deviation and basic statistical analysis was carried out. And these were the responses of the cohorts of no mix and after doing, and these were the responses that you can see. With the lowest rating recorded was actually okay, with 12% and 10%. And here also, did the simulator help you in hand-eye coordination, with the responses predominantly being excellent and good, and if not slightly improving as well. And this was the third question of the satisfaction levels. Again, the lowest rating was recorded okay, and the excellent percentage 57 that you can see. And then, did the simulator provide adequate visual feedback? There seemed to be some poor responses in this, but definitely it was still guiding them. Did the simulator provide tactile feedback? Again, the responses was poor before, but Then they felt that the tactile cognition was improving. How much did it improve your confidence? We had some more responses of poor ear, and then likelihood of making reduction of making complications, and then the scale of rating it. Again, the lowest rating was just okay, and then safe environment was a big thumbs up, as well as recommendation was a big thumbs up. Again, going back to the Likert scale, each 10 scale was actually evaluated with a percentage mapping, and each of the 10 questions were divided depending upon the cumulative score. The percentage was arrived by dividing it by 120 into 100, and then the mean was calculated with the standard deviation, which was statistically significant as well. As you can see with the negative confidence interval highlighting that the significant difference, especially combining the above two data, showed that the second group was significantly better than the first group. The discussion pertained with that no mixed experience, and after doing, definitely their cognition is improving with these kind of simulative learning, and real-time experiences once they exposed to a simulator gave them a good thumbs up. And some few points which gave a good quality factor was the users felt if you can add annotations, or if you can slightly improve the tactile nature, like synchronizing a tactile system with the HoloLens that we actually collabed with, would really mean a lot. And proper anatomy, expanding the anatomy beyond the angle was one feedback, and expanding it to a wide range of surgical equipments and a wide variety of surgeries, detailed steps of other surgeries were some of the feedback, and these were some of the component 3 of the quality. So to summarize, it's a medical virtual novelty, and it's a self-built portable one made in Trichy, Tamil Nadu, India. Easily accessible and portable, improving the quality of care and cost effective and accurate. It's something that is at your hand and with a simple headset, and this application is no financial disclosure, it's free of cost as well, launched at the Meshwork of Microsoft. So this is a one of its kind, with, according to my knowledge, a real-time, high-resolution, augmented reality, photoreal visuals for interactive 4D simulation, and especially MIGS, which is making all the inroads in the field of minimally invasive glaucoma surgery. It surgically trains and simplifies learning, and it's available open access, cost effective. And this, my dear friends, is not a science fiction anymore. It's moving into a science-based reality, which is a new world of 4D metaverse that I have coined, and I've also patented regarding the same. So thank you for this opportunity once again. Thank you.
Thank you, Prasanna. Thank you very much. We have 30 seconds left. Any questions or comments from anyone in the audience? I just had one question. The mean standard deviation of the points that you showed,
Yes, sir.
no MIGS and MIGS, that is surgeon not having any prior experience of MIGS, or this is before and after the device usage?
Sir, the left side of the table went with the surgeons not having any experience with the procedure, but they, again going into the details of it, they are all practicing glaucoma to an extent if you divide them into a different cohort. So they are wanting to do the mixed procedure, but the challenges are we don't have a model, or it's more of like a self-taught or a upgraded surgery. So the same people went into the next cohort in terms of after doing it, how did they feel the simulator? Before doing it, how did they feel the simulator? That was an intervention arm as well, sir.
Right. Thank you so much. I
Thank
think
you.
it's amazing, exciting days ahead
Yes,
as trainees. Sometimes makes me want to become a baseline trainee all over again.
Yes, sir. Then 2010, when I watched Iron Man movie, that was always there with me, sir. And Blade Runner 2047 also, the hologram that came in Blade Runner, that was always there in my mind. Can we really do something like this? And we cracked this code in the year 2021. And now we are working on vertical and horizontal chop as well as capsular access as well.
Right.
Thank you, sir.
Thank you so much.